Welcome to nursebazaar.com. Today our topic is chronic obstructive pulmonary disease (COPD). COPD is characterized by airflow limitation that is not fully reversible. Airflow limitation that is not fully reversible. So there will be a limitation or problem in the airflow into the lung. COPD include emphysema and chronic bronchitis. So two conditions, emphysema and chronic bronchitis, which include in COPD. Pathophysiology. Because of various reasons, there will be chronic inflammation. When there is inflammation in the lung, our body will attempt to repair it. So when there is injury and when our body repair this process, injury and repair process cause scar tissue. So there will be a scar tissue formation in our lungs because of this injury and repair process. So because of scar tissue, the airway will be narrowing. So there will be narrowing of the airway, which cause airflow obstruction. So that is the pathophysiology of COPD. Risk factors for COPD. Main thing, cigarette smoking, also passive smoking, then occupational exposure, then air pollution, then there is genetic abnormality. Genetic abnormality means including a deficiency of alpha-1 antitrypsin. This enzyme helps to prevent the destruction of lung tissue. So this enzyme, alpha-1 antitrypsin, it's an enzyme which will help to prevent destruction of lung tissue. So if any people who doesn't have alpha-1 antitrypsin, there is a chance to get COPD. So I told before two conditions, chronic bronchitis and emphysema. Let's see about these two conditions. First is chronic bronchitis. It is inflammation of bronchial walls and hypersecretion of mucus. So in chronic bronchitis, what is happening? There will be inflammation of bronchial walls and hypersecretion of mucus. So there will be a hypersecretion of mucus and inflammation, and the patient will have chronic cough and sputum for at least 3 months. Chronic cough and sputum for continuous 3 months. That is chronic bronchitis. But when it comes to emphysema, what happened here? Here over distension of alveoli walls. So your alveoli, you know the alveoli, this alveoli will become over distended like a balloon. It will be over distended and it will destroy. So this alveoli wall will destroy. Before destruction, it will become over distended like a balloon, then it will destroy. So that is the difference between chronic bronchitis and emphysema. When it comes to clinical features, chronic bronchitis patient will be obese patient. Okay, we can see the patient become obese because this patient will not do more exercise or more anything because they have the problem of hypoxia and hypercapnia. So they will sit and they will not do more exercise or anything, so they will become obese patient. But emphysema patient, thin patient, they will become thin because in emphysema the problem is the alveoli is destroyed. So if the oxygen is coming into their lung, they cannot use this oxygen. So this oxygen will not go to alveoli because there is no alveoli bed, and this, so because lack of alveoli, the oxygen will not go to the blood and to the tissue. So this patient will have more dyspnea, more problem. So they will try to get more oxygen. So always they will work for getting oxygen. So they will become thin patient. But in chronic bronchitis, they have some dyspnea, but it is not that much severe like emphysema. Then in chronic bronchitis, you can see cough and sputum. That is the main symptom. In chronic bronchitis, cough and sputum is the main symptom. But in emphysema, dyspnea is the main symptom. Dyspnea. Then chronic bronchitis people otherwise called as a blue bloaters. I will tell you why it is a blue bloaters, because here what is happening, airflow is limited because of hypersecretion and other problem. The oxygen is not coming to lung because the airflow is limited. There is a narrowing of the air lumen, airflow, so they are not getting enough oxygen. So there will be hypoxia, hypercapnia and cyanosis. So they are called as blue bloaters. But when it comes to emphysema, they are getting oxygen is coming to their lungs because there is no like narrowing of lumen or anything. Here the problem is there is no alveoli, so oxygen is coming to their blood, lung, then from lung to go to blood, to go to our blood, there is no proper alveoli, so they cannot use the oxygen which is coming to their body. So even though what they will do, they have the dyspnea or other problems, so they will take more and more oxygen. So because of this work, they will have a pink appearance, because they work more and more to get the oxygen. They breathe more and more to get the oxygen, so their body will be working always, so they will appear like a pink color, that is pink puffers. But in chronic bronchitis, the problem is they are blue blotters, because they are getting oxygen, so they there will be hypoxia and hypercapnia, so that is a blue blotter. So blue blotters for chronic bronchitis and pink puffers for emphysema. Then this patient, emphysema patient always sit in a tripod position. I will show you what is tripod position. See, this is the tripod position, sitting, leaning forward with the arms and elbows supported on over a bed or table, that is tripod position. So because this will help to take them oxygen easily. Okay, next is, you can see barrel shaped chest in emphysema. Barrel shaped chest means you can see the normal chest here, then this is the barrel chest. Okay, so the diameter will be different, that is the barrel chest. So when you see a patient with this type of problem, you can suspect COPD. Okay, next, management. For the management, the first one is stop smoking, then bronchodilators, you can use bronchodilators, then corticosteroid, then give alpha-1 antitrypsin augmentation therapy, because before I told that lack of this enzyme will cause problem to the lungs, so we will give externally alpha-1 antitrypsin augmentation therapy. Then antibiotic, you can give mucolytic agents to lyse or break down the mucus, then antitussive agents, then oxygen therapy. When you give oxygen therapy for a COPD patient, you have to be very careful. It is not like the other patient, because if you give more oxygen and make this patient oxygen level above 95%, what will happen? They will not initiate more oxygen, initiate more breathing. One thing that when a patient blood is having less oxygen, then they automatically start to do the breathing. Respiratory drive will activate and they will start to do the breathing. So if you give more oxygen to the patient or a COPD patient, their blood is having enough oxygen, so they will not start or initiate more breathing. So it will affect their into other problems. So always keep the patient oxygen saturation level 88% to 92%. So when you give oxygen, you check patient's saturation and make it into 88% to 92%. Don't go more than that, because if you give more than that, patient will not initiate any breathing, so it will affect and do another problems. Then you can give a breathing exercise. Then bullectomy means removal of bullae means a dead space or non-working alveoli part is called as a bullae. So you can remove the bullae, that is bullectomy. Then lung transplantation. These are some of the management. Then complication: respiratory failure, atelectasis means collapse of the alveoli, then pulmonary infection, pneumonia, pneumothorax, then pulmonary hypertension. Thank you for watching this video. Please subscribe our video. For online nursing coaching, contact www.nursebazar.com or WhatsApp me on 00971 522069 9493.